So let's do Barry's 3 questions and then I'll introduce them. So the first question is, which of the following statements is correct? The left ventricle in systolic heart failure displays decreased afterload sensitivity. Number 2, the cardiac myocytes in systolic heart failure display enhanced calcium handling. 3, outpatients with systolic heart failure typically have normal vital signs and cardiac output. 4, the left ventricle in systolic heart failure displays increased preload sensitivity. Or 5, anemia, liver abnormalities, and renal dysfunction and muscle wasting are often present but do not affect outcomes in patients with systolic heart failure. Which one of those wordy sentences is correct?
It's real life words. Lots of words.
Everyone's reaction time is slower after the alcohol last night, I think. All right, so 57% of you said number 4. Okay, question number 2. Which of the following statements is not correct? Coronary artery disease is the leading cause of systolic heart failure in the U.S. 2, rate control is the key first step in a patient presenting with tachycardia and LV dysfunction in the absence of congestion or other obvious etiologies. 3, infiltrative cardiomyopathy has the worst survival among causes of systolic heart failure. 4, 1 to 2 glasses of red wine per day taken chronically causes LV systolic dysfunction and heart failure. Or 5, at least 20% of patients with apparent idiopathic dilated cardiomyopathy have a family etiology. Okay. Question number 3. Which of the following is not correct? Echo is indicated in all patients with history, risk factors, and physical findings suggesting possible systolic dysfunction. 2, CAD should be excluded in virtually all patients presenting with new systolic heart failure. 3, the absence of RALs effectively rules out high LV EDP in patients with systolic heart failure. 4, jugular venous distension is the most useful physical exam finding identifying congestion. Endomyocardial biopsy is indicated with recent onset symptoms of severe heart failure with hemodynamic or electrical instability. Which of those is not true? Okay, so Dr. Barry Borlaug is going to kick us off this morning with a discussion about systolic heart failure. Barry is a heart failure specialist, obviously. He is a hemodynamic guru. He teaches niche about pressure volume loops and does a great job of putting things together. And we should feel some pain for Barry and for Mike and for myself with Jordy Nelson hurting his ACL. Last week. It makes our season not look so good coming up. So I guess you're going to have to focus on heart failure and not football this year.
Yeah, thanks for taking me down here before the
thanks.
talk.
Yeah.
Okay, thanks, Steve. All right, good morning. So these are my relationships. They're not really relevant to what I'm going to talk about. So these are the learning objectives. We'll talk about the biochemical and pathophysiologic mechanisms of heart failure, and then we'll talk about how to evaluate these patients and how to choose appropriate diagnostic tests. So objective 1, pathophysiology and biochemical of myocardial failure. So it all starts out with some insult to left ventricular function. It can be something big, like an anterior MI, or something slow and indolent, like a genetic defect. But this eventually leads to a depression in cardiac output and a drop in blood pressure, which then causes neurohormonal activation. And within seconds to hours, there's increases in sympathetic nerve activities, increase in renin-angiotensin-aldosterone, and arginine vasopressin. And those things then start to maintain this. They increase renal sodium retention to increase preload by the Frank-Starling relationship to enhance cardiac output, and then there's tachycardia and vasoconstriction and increases in contractility. So all of these things are designed teleologically to maintain blood pressure and cardiac output in the homeostatic range. So this is a very good response if you're exsanguinating because you've been bitten by a tiger or if you're out in the desert. But chronically, activation of these neurohormonal pathways are really what underlies HFrEF. And by HFrEF, heart failure with reduced EF, I mean systolic heart failure. They're the same thing. The term that's currently used is HFrEF, so I probably use that a little more frequently. An important point is that the body's adaptation or maladaptation really to the initial insult is really what drives the progression. So we really want to remember that in terms of the pathophysiology and the treatment. Now, every year I am told repeatedly that I talk too fast. So I'm going to slow it down for this slide. So this is very board-worthy stuff, and let's just go through it. So excitation, contraction, coupling. So here's what happens. Calcium comes in, binds the L-type calcium channel. A little bit of calcium comes into the cardiac myocyte, activates the ryanodine receptor on the sarcoplasmic reticulum, the SR. That's where the calcium is stored. That then leads to calcium release. From the SR, calcium then binds to the filaments and initiates the onset of contraction. More calcium, more contractility, less calcium, less contractility. The contraction cycle comes to an end. The calcium then needs to get out of the cytosol. The two ways it can do that are going back into the sarcoplasmic reticulum through this protein called the SERCA, the sarcoplasmic reticulum calcium ATPase, which is inhibited by this thing called phospholamban. Or calcium can go out of the cell through the sodium-calcium exchange protein. Okay, so that's the normal response. What happens in heart failure? In general, there's abnormal calcium handling. So there's less calcium for each beat in general. And there can be abnormalities in this SERCA, so there's less calcium taken back up in here. There is more calcium escaping out this way. If there's less calcium coming back into the SR, you're going to have less calcium available to stimulate contractility in the following beat. There is increased inhibition of SERCA by phospholamban. So phospholamban is a protein which inhibits this uptake. That's also abnormal. There's abnormality in the interaction between the L-type calcium channel and the ryanodine receptor. So less calcium, abnormalities in calcium handling, especially with increases in heart rate. That's called an abnormal force frequency response. So that's kind of a basic science type question which could show up. The other pathway to be cognizant of is the beta pathway. So normally epinephrine or norepinephrine activates a beta receptor, which stimulates G protein coupled receptors and adenylyl cyclase, which increases cyclic AMP levels, which then activate protein kinase A, which then stimulates all these things. So it increases the amount of calcium coming through the L-type calcium channel. It improves the uptake of calcium into the SR by inhibiting phospholamban, which inhibits SERCA. In heart failure, there is, for any amount of beta stimulation, there's less cyclic AMP, basically. And it's due to differences in the amount of beta 1 versus beta 2 receptors. Remember, it's the beta 1 that's doing these positive effects. And there's abnormalities in downstream signaling. So it's worthwhile kind of remembering this pathway, pKa, cyclic AMP, stimulating contractility, stimulating heart rate, and lusitropy, which is diastolic function. All of that has been clearly shown to be impaired in patients with systolic heart failure. Okay, so here's a really bad cartoon of a normal ventricle. Chronic neurohormonal hyperactivation leads to LV overfilling from the volume overload and eccentric remodeling. Remember Laplace's law. This was on my boards. Wall stress varies with chamber pressure and radius in the numerator divided by wall thickness in the denominator. This is normal. This looks like somebody with severe AR, but this could just be somebody with severe HFrEF. Dilated ventricle, the ratio of chamber dimension to wall thickness is very high, and of course the filling pressures are high. This does many things. Obviously it increases wall stress, that then increases O2 demand, decreases pump efficiency, causes functional mitral regurgitation, which we often see, and begets electrical and mechanical dysynchrony. So these are all bad things. I think it's worthwhile understanding qualitatively the neurohormonal abnormalities. Again, we talked about this before, but all of these things, norepi, angiotensin II, aldosterone, endothelin, they do bad things. They stimulate maladaptive hypertrophy, they promote remodeling and fibrosis, they lead to vasoconstriction. There's much fewer sort of anti-remodeling things, the natriuretic peptides, nitric oxide, and prostacyclin. They just basically counter what is happening with these bad players. As we'll hear in the next lecture, drugs that antagonize these things work unequivocally in HFrEF. Trials have tested these agents, either antagonizing these or stimulating these pathways, and they have not been shown to work, and the jury's still out on new ways to modify the nitric oxide pathway. Okay, so hemodynamics. This is key to understand. So this is a pressure volume loop. So pressure is on the y-axis, volume's on the x. Here at the bottom right is the end diastolic volume, which is the true preload of the ventricle. That, of course, is the end systolic volume. The difference between the two is, of course, the stroke volume. And you can see the ratio, there's no units down here, but the ratio of the stroke volume to the end diastolic volume is about 50, so the EF is 50%. You should be able to figure that out graphically from an exam. Systolic blood pressure, peak systolic blood pressure is up here. End diastolic pressure is here. The shaded area subtended by the PV loop is the stroke work performed by the ventricle. Now, if you really want to understand ventricular properties, you can't just look at one beat at a time. You need to see what happens when you modify preload. And in research studies, we do that by decreasing venous return to the heart by interrupting blood flow to the IVC with a balloon. And when you do that, the end diastolic volume goes down, down, down. And the end systolic pressure goes down, down, down. The stroke volume decreases. But contractility stays the same because you're doing it so acutely. So if you then connect these end systolic pressure volume coordinates at each of these beats, you generate a straight line, which is called the end systolic pressure volume relationship, the ESPVR, and that was in the pretest slide that Steve showed earlier. The slope of this ESPVR is a measure of contractility. So if it goes up like it did in that example, that is enhanced contractility, like you might see with isoproterenol. If it goes down and becomes more shallow, that's what you'd see in somebody with HFrEF, or somebody who maybe gets a beta blocker, propranolol, something like that. This curvilinear relationship down here in diastole is the end diastolic pressure volume relationship, or passive stiffness. And we'll hear some more about that later this morning when Maggie's talking about heart failure with preserved ejection fraction. But basically in patients with increased diastolic stiffness, that relationship is shifted up and to the left, like I'm showing here. Less intuitive for the boards, but I'm including it for completeness, is what's called effective arterial elastance, or EA. This is afterload. This is the ratio of end systolic pressure to stroke volume. So it makes sense intuitively. If pressure is high and stroke volume is low, that's kind of telling you that that's a higher afterload state. So afterload goes up, it would be like this. Blood pressure is going to increase, stroke volume is going to go down. And if you give a vasodilator and it goes like this, blood pressure is going to go down and stroke volume is going to increase. Okay. So this is what happens in HFrEF. So here's a normal person, like we just showed you. In people with what we call stage B heart failure, people with structural problems in their heart, this is what we see. We used to call this asymptomatic LV dysfunction. They have a dilated heart, so the end diastolic volume is increased, but the stroke volume is the same as the normal person. The EF is low in this patient because the denominator of the equation is high. So stroke volume divided by EDV is high, but the blood pressure looks normal and the stroke volume and cardiac output are normal. And that's one of the questions in the pre-test. Stage C, which is most of the patients that we take care for in the clinic and on the wards, patients with symptomatic heart failure, they're a little bit more remodeled, so the ventricle is bigger, but they still usually have a normal stroke volume and they still usually have a normal blood pressure. Because they have symptoms, they usually have an increase in filling pressure. So you can see the bottom right here, the end diastolic pressure is starting to go up. Now, it's not until you get to stage D, which is the most advanced patients with heart failure, where you start to see a drop in blood pressure, a decrease in stroke volume, they're starting to get more reflex tachycardia, and now a very profound increase in filling pressures. And you can see the chamber volume is really high. So this is the progression, and the drugs that we give are designed to move these patients back or prevent them from moving forward to the right. So this is what we want to avoid. These are the people that need LVADs and transplants like Dr. Clavel is going to talk about. So a very important point to remember, the failing ventricle in HFrEF is exquisitely afterload sensitive. So what do I mean by that? So here's a normal beat, here's systolic heart failure. This patient is dilated, so it's shifted way out here, and they have this very shallow ESPVR, depressed contractility. Why is that important? Because if I give phenylephrine or a vasoconstrictor, I see an increase in pressure and a reduction in stroke volume. If I give the same dose to the HFrEF patient, the same things happen, but look at the difference. There's less increase in blood pressure, there's a much more dramatic drop in stroke volume. So these people really tolerate vasoconstrictors very poorly. Conversely, if I give a vasodilator, like in the lab, I give some nitroprusside, I see a huge drop in blood pressure in the normal person, slight improvement in stroke volume. If I give the same dose to the HFrEF patient, again, because of this shallow relationship, there is much less drop in blood pressure, so that's good. There is much more improvement in stroke volume. The width of the loop is getting very good. So the very favorable response to vasodilators. And this is really the hemodynamic reason why we push vasodilators in patients with HFrEF, above and beyond the neurohormonal hypothesis. So this is very important to remember, and most patients tend to be undertreated in terms of their vasodilators with chronic HFrEF. So increased afterload sensitivity. This question was, I think about 67% of people got this wrong before, so pay attention here. So in HFrEF, there is decreased preload sensitivity. Now I'm using the word preload a little bit incorrectly here to refer to filling pressures. That's not really what preload is. Preload is really volume, but we often put the two together. So this is a Starling curve in a normal patient, relating filling pressure to stroke volume or stroke work in this case. And if you give a diuretic or a nitrate, something to decrease filling pressure, this is what happens to a normal person. There's a drop in stroke volume and stroke work, and their heart rate's going to go up, and they're going to compensate for that. Now, if we take a patient with systolic heart failure, they have a depressed Starling curve, so this slope here is lower than this slope. That's another indicator of lower contractility, and then it sort of reaches this asymptote. So if I give the diuretic to this guy, I see no drop in stroke volume or stroke work, but I do see a big reduction in filling pressures and the patient feels better. So this is really why we're pushing the diuretics when they're inpatients on the service. This is how this works. Now, in some patients with really advanced HFrEF, they look like this. This is the so-called descending limb of the Starling curve, which at the myocyte level probably doesn't exist. I'm going to show you why it probably does exist at the chamber level. But you give this patient a diuretic, and actually we see this apparently paradoxical improvement in stroke work. So how does this work? Well, this is due to this phenomenon called diastolic ventricular interaction, which we think about in pericardial constriction, but it's also very applicable in HFrEF. So here's a parasternal kind of cartoon of a normal person, and if you do something to decrease venous return to the heart, like suction to the legs, so there's less blood coming back into the central circulation. The RV gets underfilled, so it gets smaller. The RV pumps less blood to the LV gets smaller, the stroke volume goes down, the heart rate goes up, etc. Great. So what happens in somebody with advanced HFrEF that looks like this? We do this same lower body suction, but they've got this big distended RV that's crowding out their LV. Now there's less blood coming back to the RV with a diuretic or with a nitrate or the suction experiment. And the LV then can take advantage of this and fill much better. So we see this all the time. It turns out we can estimate these LV filling pressures, these net distending pressures, by what's called the transmural pressure. And that's the difference between the left heart pressure, or the wedge pressure, and the pericardial pressure, extrinsic to the heart. Pericardial pressure is basically the same as right atrial pressure. So here's a patient who comes in with bad heart failure, azotemia, very high pressures, but the difference between the left heart pressure and the right heart pressure is very small. If you did an echo, they'd look like this, small underfilled LV. Transmural pressure, this difference is very low. It's an underfilled LV. We give this patient a diuretic for a couple days, we recath them, and we see this. Pressures have come down on both sides, but they've come down more in the right heart. So that right heart is more decongested. That's allowing the left heart to fill better. The transmural pressure is increased, and that creatinine has gone down, and the BUN has gone down, even though we've been giving a diuretic. This is a very, very important thing to understand in the management of patients with systolic heart failure. Other common hemodynamic findings that we see, pulmonary hypertension. So note the scale here is very high pulmonary artery pressures, secondary to high left heart pressures. Functional mitral regurgitation, very, very common, especially in stage D, often in the absence of much of a murmur. Here you can see some huge V waves, but remember, big V waves are neither sensitive nor specific for HFrEF. And functional tricuspid regurgitation. That chronic pulmonary hypertension, the RV dilates and gets weak, and you dilate the tricuspid annulus. So pulmonary hypertension is very common. Remember the equation. Mean PA pressure equals PVR times cardiac output plus the downstream left atrial pressure. And in early stages of heart failure, you have this high LA pressure, but everything here in the lungs looks pretty normal. That's called passive pulmonary hypertension. That's pretty good. You just give a diuretic. Patients with more advanced, long-standing left atrial hypertension start to get remodeling of the pulmonary vasculature. The transpulmonary gradient, the difference between the mean PA pressure and the mean wedge pressure, starts to go up. The pulmonary vascular resistance, the transpulmonary gradient divided by the cardiac output, starts to go up. And you start to get more of an out-of-proportion increase in the pulmonary artery pressures, and this is associated with worse outcome in patients with heart failure with reduced EF and preserved EF. Why is that? Well, the RV, we know, is not well suited to pumping against high pressures. This is an old dog experiment from many years ago. Bigger drop-off in pressure, or in stroke volume, with any increase in pressure in the right ventricle as compared to the left. Lots of extracardiac sequelae. Liver dysfunction, especially in people with chronic central venous pressure elevation from right heart failure, anemia, endothelial dysfunction, oxidative stress, and sleep disordered breathing, very, very common. Brand new study questioning the benefit of treating central sleep apnea with positive pressure ventilation. Not going to be on the boards, but just for your information. Renal dysfunction is very, very common, especially in people that are hospitalized. It actually is more related to congestion, to high right atrial pressure, which increases the renal venous pressure, than it is to low cardiac output. So again, this is another reason why we push the diuretics hard, because if we can get those central venous pressures down, we often see the renal function gets better. Clearly, patients with lower GFR in heart failure have much worse outcomes, so it's a strong, strong indicator. And BUN is actually even a better indicator than creatinine of outcome in HFrEF. There's abnormalities in the periphery. I'm not going to get into this. I think I would just understand qualitatively that there are changes in type 1 and type 2 fibers. There are changes in oxidative phosphorylation and abnormalities in the muscle that importantly drive symptoms in patients with HFrEF as well. There's inflammation. There are increases in TNF levels. You can even see endotoxemia, which improves when you decongest patients. You can see increased levels of LPS and interleukins and CRP, and that's also predictive of adverse outcome. So any marker of inflammation on the test, you are going to say that that is an indicator of adverse outcome in HFrEF. This does lots of bad things. directly contributes to LV dysfunction, and a whole host of other problems, as you see here. Okay, so that's pathophys. Let's talk about how we evaluate and what are the causes. So clearly, in the United States, coronary disease is the most common cause, 2/3. Usually, you know, there's Q waves, or they had a prior MI or a couple MIs, but sometimes they don't have any antecedent history. It's about 7% of people coming in with apparently a primary dilated cardiomyopathy, and you do an angio, and actually they do have 3-vessel disease. So we really want to come back to looking for that. We want to look hard because it's a reversible cause. So there's a huge upside to finding that and treating that, and we'll come back to that in a little bit. The next most common single cause would be idiopathic or primary dilated cardiomyopathy. It's really a diagnosis of exclusion. In people where we didn't know if they had coronary disease or other known causes, it's about 50% of those cases. And really, it's just after you've excluded everything else. Now, a lot of these people probably have a genetic cause, and we're just not good enough with our genetics. So at least 20% of these patients probably have a familial cause. Toxins, always important to think about. Alcohol. I see this one thrown around a lot. It's pretty big boozing to cause LV dysfunction. 7 drinks a day for like 5 years. So it's not the, you know, a little bit moderate alcohol consumption, mild alcohol consumption is protective against heart failure. So that's not the cause that we would see in patients with alcohol-induced cardiomyopathy. Cocaine and all the other catecholaminergic drugs, chemotherapy, Herceptin, anthracyclines, cyclophosphamide, those are the big ones. Radiation does everything bad, right? Bad for the muscle. Often causes more of a restrictive pattern, but can also cause LV dysfunction and low EF type heart failure. Lots of different infectious and inflammatory causes. We don't usually look for these. We don't do titers of, you know, Coxsackie virus and stuff because we don't treat it differently. HIV is an important thing to consider in people with risk factors, so if that was in the stem of the question. Giant cell, we'll come back to that. That's another important one to try and identify because we would treat those patients a little differently. As I mentioned before, probably at least 20 to 30% of patients with apparent primary DCM actually have a familial cause, and there's a whole host of different causes. ARVD, like shown here in the ECG with this epsilon wave, muscular dystrophies, et cetera, et cetera. So take a careful family history, and somebody with a primary dilated cardiomyopathy, because so many of them are familial, I will usually tell my patients to have your first-degree relatives get a screening echo and ECG just to make sure they don't have it too, because it often is genetic. Peripartum is kind of a favorite of the boards. It's defined as the development of new heart failure and low EF in the absence of other clear-cut causes in either the last month or the first 5 months after the baby's born. A number of risk factors. It's not clear whether it's immune or whether some of these women just had pre-existing LV dysfunction and just the hypervolemia and stress of pregnancy brought it out. Half of women normalize their EF at 6 months. They have a very good prognosis. The other half don't, and theirs are worse. Remember, you don't want to give ACE inhibitors or ARBs. Angiotensin, important growth hormone for the baby. You can use Iserdil and hydralazine. These other drugs are okay. And again, the women that don't normalize should really, really be strongly discouraged from getting pregnant again. Everybody knows this. Apical ballooning or Takotsubo or stress-induced cardiomyopathy looks like a big anterior MI, kind of, in that there's chest pain and ECG changes, but of course the pattern doesn't follow a normal coronary distribution. Often associated with stresses, emotional, surgical, other, but sometimes not. For reasons that are not clear, women greatly outnumber men, usually above 60. Again, the ECG and enzyme changes are reminiscent, but somewhat different. Deep Q wave across the anterior precordium, typically in these patients. This is the best prognosis. As a rule, these patients normalize, usually within about 2 to 4 weeks. So important to identify and reassure patients. Number of different endocrine or nutritional causes, as shown here. You know, obesity, we talk about, it's a huge risk factor, but as the isolated cause, not clear. Diabetes, also not clear as the isolated cause, but important risk factors also for coronary disease as well. Think about iron overload, hereditary hemochromatosis, very common in Northern European ancestry, or people that have had lots of transfusions, so we can do an MRI for that. We can do a biopsy for that. We should suspect it in people that have a high ferritin and an increased ratio of iron to total iron binding capacity, so we kind of routinely check this in our lab when new patients with heart failure. Again, gold standard remains the liver biopsy, but you can also do a heart biopsy or a cardiac MRI is quite good as well. It's important to find it because we would treat it differently with phlebotomy or in some cases chelation therapy. So again, you want to think about things that you're going to treat differently other than just ACE inhibitors, beta blockers, aldo antagonists, and digoxin. Tachycardia, really important to think about, reversible. Often hard to tell in the patient who's coming in whether their tachycardia is just because they're in heart failure or whether it's driving the heart failure, but if there's nothing else, it's often the case. There's no real advantage to rhythm versus rate control, just get the rate down. There is this entity of people that have lots of ectopy, like greater than 20, 30%, who may have a cardiomyopathy. That's probably not for the boards. Hypertension is the single most common risk factor, but isolated hypertensive cardiomyopathy is very, very rare. Of course, you're going to treat the blood pressure in these people, and sometimes the heart will get better. This is somebody with what? Macroglossia. You can see their teeth marks on their big tongue from amyloid. The infiltrative myopathies, again, usually cause more of a restrictive picture, but sometimes they do cause more of a HFrEF type pattern. They have the worst outcomes of all people with systolic heart failure, or at least they traditionally have. The drugs are getting a little bit better now. Suspect amyloid when the ECG voltage is low, but there's LVH. Confirm it with a biopsy, which is very sensitive. Sarcoid, also infiltrative, much harder to diagnose. Okay, last part, diagnostic and evaluation. This is the staging system. I think we'll hear some more about this. A is risk factors. B, structural disease but no symptoms. C, symptoms. D, really bad. That's different from the NYHA classification, which you should ascertain at each visit. 1 is no limitation. 2 is pretty mild, but they'd have symptoms. 3 is even with kind of normal everyday things like getting up to go to the bathroom, and then 4 is almost at rest. It's important for that because that comes into the guidelines for how to manage them with devices and drugs and things like that. Now, these are the Framingham criteria to make the diagnosis. 2 majors or 1 major and 2 minor at the same time is enough to make the diagnosis. These are more specific, but often not present. So if you hear a third sound, that's pretty strong. But a lot of people with heart failure don't have that. Most people with heart failure have some of these other things like exertional dyspnea. So this is what you want to do. Figure out the etiology, establish their functional class by taking a good history. Some people minimize their symptoms. Sometimes you'll do a 6-minute walk or an exercise test to refine that assessment. Definitely get an echo and establish their volume status. As you're ongoing caring for them, you want to do all those things again. You want to see if there's any med intolerance. Are they orthostatic? Are they getting electrolyte issues? Did somebody start them on a class 1 antiarrhythmic drug, which is a big no-no in HFrEF, or verapamil or something like that? And then make sure they're taking their meds, they're avoiding things which worsen heart failure like nonsteroidals, and look for triggers that might cause decompensation like arrhythmias and whatnot. So these are kind of the class 1 things, pretty duplicative of what I just said. Look for clues for etiology. Do they drink? Are there risk factors for HIV or illicit drug use? Is there a family history? Do they have angina? Have they had radiation to the chest? Things like that are pretty obvious. Physical findings, again, in the early stages of the diseases, they really look normal. If you're really good at assessing the PMI and percussing out the heart border, you might find that they're a little dilated. I'm not so great at that, so that they often look pretty normal. So if they're bad, though, they are often cachectic and short of breath. They're often tachycardic. They may have low blood pressure with a narrow pulse pressure. If that's the case, that's pretty good evidence of a low cardiac output. If you want to care for heart failure patients, get used to accurately assessing jugular pressure. It is the single most useful finding. They may have abnormal abdominal jugular reflux. The lungs are, as a rule, clear in chronic heart failure. Crackles and ralls are for acute pulmonary edema or flash pulmonary edema, not chronic heart failure. So the fellows are often saying like, well, there's no ralls, so the filling pressures are normal. Not true. People with chronic HFrEF and HFpEF adapt and have clear lung fields and radiographically clear lungs despite very high filling pressures. More likely to see effusions. There may be a soft S1 because the ventricle is weak, so the forces governing closure of the mitral valve are diminished. There may be a loud P2 if there's pulmonary hypertension. You may hear murmurs of MR and TR, but they may be absent even if there's significant valvular regurgitation, often functional. They may have a big liver, they may have ascites. If the extremities are cold, that's an indicator of low SVR. High SVR, excuse me. A high SVR is indicative of a low cardiac output, as is pallor. They often have edema from venous congestion. Pulsus alternans, if they have this, where every other heartbeat, the systolic pressure is up, down, that's a very strong indicator of a low cardiac output. Hard to feel, easier to hear. It's kind of old school to take a blood pressure yourself with a stethoscope, but it's pretty useful, and that's a good way to identify people with pulsus alternans. So again, JVP or RA pressure varies with wedge pressure. It's the strongest indicator. If you do a 2x2 table, there's a very strong agreement between people with high jugular pressure and high wedge. So if your jugular is high, most of the time, 101 divided by 107, you are going to have a high wedge pressure. So you can usually take that to the bank. Less common, you can still have a high wedge pressure with a normal RA pressure, but again, if it's high, it's very useful in patients with heart failure. Of course, general laboratory evaluation, we get BNPs, especially the first time around, very often. It's believed to have a high negative predictive value. It's often normal in HFpEF. We'll hear about that later, who are well compensated. If a patient is short of breath acutely, though, you would expect their BNP is going to be high if it is related to heart failure. Chest X-ray, ECG, echo for everybody, obviously. Other things are really dictated by the clues in the stem of the question or in real life, obviously, iron studies, HIV risk factors, etc. Cardiopulmonary testing, we'll hear some more about. We need that to establish candidacy for advanced therapies like transplant. We want to think about sleep-disordered breathing. MRI is really increasing but continues to be an evolving modality, but there are certain disorders like the hemochromatosis and some of the other infiltrative diseases or myocarditis where this can be useful. As a rule out coronary disease. Remember I told you before, it's 2/3 of all the patients. These are the guidelines. Class 1 if there's angina or known ischemia, or 2A if there's some atypical pain. Stress testing is okay in the guidelines. I will tell you in our practice, we see a lot of false positives and some false negatives too. Unless it's a patient that I would not revascularize, like a 95-year-old woman who is nearing the end from other reasons, I probably wouldn't do it then. But if there's any other reason where you would revascularize them, usually just do an angiogram and put it to bed. Last slide, biopsy. When is this indicated? Well, not that often. It's usually not indicated for HFrEF. It's class 3 for routine evaluation, so absolutely don't do this routinely. Like any test, you are going to do it when the results are going to influence therapy. So it's one of these things that you would treat differently if you knew that information. And the big one here that I have highlighted is giant cell myocarditis. These people are usually a bit younger, and they have a very rapidly progressive new onset heart failure, usually within 2 weeks. Remember that question, 2 weeks. That's what the guidelines say. They often have electrical instability. They may have shock, so they're going to have jugular distension. They'll be tachycardic. They may be having runs of non-sustained VT. That's the kind of patient you want to do a biopsy, because if they have giant cell, we are going to hit them hard with immunosuppressive medicines, and we're going to call our surgeon to come evaluate them for a VAD, because they may need that soon, because those patients can go down quickly. So I think that's the last before the question. I will stop there. Thanks for your attention.
Okay, nice job.
Thank you.
So, let's go back through the pretest questions. Which of these following sentences is true. The LV in systolic heart failure displays decreased afterload sensitivity. 2, cardiac myocytes in systolic heart failure display enhanced calcium handling. 3, outpatients with systolic heart failure typically have normal vital signs and cardiac output. 4, the LV in systolic heart failure displays increased preload sensitivity. Or 5, anemia, liver abnormalities, renal dysfunction, and muscle wasting are often present but do not affect outcomes in patients with systolic heart failure. Which is true?
Okay, good, excellent improvement. So that is correct. They usually have normal vital signs, normal cardiac output, normal stroke volume. Afterload and preload sensitivity, again, remember, that means how sensitive is the ventricle to those two things. Afterload, very sensitive. So that's why we push the vasodilators. If they get an increase in afterload, if they start taking a bunch of Sudafed, or if you give them, somebody gives them phenylephrine in the ICU and they really go into pulmonary edema, that's because that ventricle can't pump against high pressure. High afterload sensitivity. Big benefit from reducing that with vasodilators. Preload sensitivity, again, a little tongue-in-cheek here with preload. Preload really is stretch. It's how big the ventricle is, the end diastolic volume. But in this question, I'm talking more about filling pressure, like EDP or wedge pressure, and that's actually decreased. Remember that flat Starling curve that I showed you earlier? They're way out here on the asymptote of the Starling curve. We give them the diuretic, we bring them down so their filling pressure gets much lower, but they usually don't need that high pressure to achieve an adequate stroke volume. Stroke volume stays the same, filling pressure gets better, patient is less short of breath. So they have decreased preload sensitivity or decreased sensitivity to filling pressure. Very important to remember.
All right. Question number 2. Which of the following is not true? CAD is the #1 cause of systolic heart failure in the U.S. 2, rate control is the first step in a patient presenting with tachycardia and LV dysfunction in the absence of congestion or other obvious etiologies. 3, infiltrative cardiology has the worst survival amongst causes of systolic heart failure. 4, 1 to 2 glasses of red wine per day taken chronically causes LV systolic dysfunction heart failure. Or 5, at least 20% of patients with apparent idiopathic DCM have a familial etiology. Not bad.
Excellent.
All right. What did they do? They did pretty well the first time around, though, too, didn't they? But they.
It was, yeah, it wasn't 91,
62.
though, yeah.
Yeah, excellent. Okay, question number 3. Echo is indicated for all patients with a history, risk factors, and findings suggestive of systolic dysfunction. 2, CAD should be excluded in virtually all patients presenting with new systolic failure. 3, the absence of RALs effectively rules out high LV EDP in patients with systolic heart failure. 4, JVD is the most useful physical exam finding for identifying congestion. Or 5, endomyocardial biopsy is indicated with recent onset symptoms of severe heart failure with hemodynamic or electrical instability, which is not true.
Oh, excellent. As a tear of pride is streaming down my cheek right now. Tear of pride.
It's nice to know that you can be so easily excited. All right. Yeah, excellent lift, too. 64% to the 90s. All right. I think there was...
And then we have some other questions.
We have some other questions, which are nice to do. So the yellow pressure volume loop was taken at baseline. A drug is given, and the PV loop after the drug is given is shown in blue. Which drug was given?
Nice.
Not bad.
Guaranteed to have a few of these on the board. So, so what happened? Blood pressure went up, stroke volume went down, pressure, right? So increase in afterload, phenylephrine.
So one of the questions that came in on the portal while you were talking was, can you kind of review how often does hypertension result in LV systolic heart failure, and how about sleep apnea as principal causes?
You know, for hypertension, it is the single largest modifiable risk factor, or it has the highest population attributable risk for heart failure. But a lot of that is mediated through other things like coronary disease. So as the only cause, it's pretty rare. So it's not a very common cause, just pure hypertension. Sleep apnea is a common comorbidity in heart failure, but we don't consider that to be sufficient to call that a cause of heart failure. So a lot of them have, like everybody in America has a lot of obstructive disease. If they have central sleep apnea, it's usually travels with more advanced heart failure, low cardiac outputs, things like that.
All right, eccentric. Is that you?
Yeah.
Okay.
Yes. Eccentric doctors write eccentric questions.
Eccentric left ventricular remodeling causes each of the following except A, non-valvular MR, B, decreased wall stress, C, increased myocardial oxygen demand, D, increased LV mass, or E, increased B-type natriuretic peptide release. It causes all of the following except which?
Looking for 95 plus here. Okay. Well, that's not 95 plus. So eccentric remodeling, dilated ventricle, the fundamental underpinning of HFrEF. So remember the law of Laplace. Wall stress or wall tension varies directly with chamber dimension and filling pressure, and inversely with wall thickness. That increases with all of these processes, increases myocardial oxygen demand, increases LV mass. BNP is stimulated from stretch. So when the chamber is stretched, that causes more BNP release. And then, of course, functional MR, because the mitral annulus and subvalvular apparatus gets tethered, so you get this functional MR. So all of those things happen.
All right. A 45-year-old man with a history of hypertension presents with mild dyspnea. He doesn't have angina or dizziness. There's no other significant past medical or family history. He drinks 4 to 5 glasses of red wine per week and denies tobacco or other drug use. He's on amlodipine and chlorthalidone. Blood pressure 134, heart rate 125, no JVD. Lungs are clear and the heart is irregularly irregular with a 1/6 early peaking systolic ejection murmur and no gallop. There's a trace of edema. Potassium is 4, creatinine 1.2, BNP 227. His heart looks a little big on chest x-ray, but clear lungs. His echo shows mild LV enlargement with global hypokinesis and an EF 35%. What will you recommend? 1, enalapril heparin and a stress test. 2, diuresis heparin and a right heart cath. 3, encourage him to stop drinking alcohol and reassess his LV in 3 months. 4, heparin, enalapril, metoprolol, and warfarin. Or 5, RV biopsy and immunosuppressive therapy.
Okay. That's good.
Yep.
So, yeah, I mean, the key, a lot of these are kind of right, and that's often how the board's questions are, like, yeah, enalapril, sure. LV dysfunction, you want to give them enalapril. The key, the most important thing here is to get a beta blocker to get that rate down. This is, the picture here is somebody who probably has tachycardia-mediated cardiomyopathy from rapid AFib. And it's usually these people that have no awareness of AFib in terms of the palpitations. So they're in it for a long time, and then they come in with symptomatic heart failure. So that would really, before we're doing a cath and all this stuff, we'd probably just try and get their rate control and then get them, do another echo in a couple months.
Ways in which the cardiovascular system responds to reductions in systolic function include all of the following except 1, activation of the sympathetic nervous system. 2, venoconstriction to augment ventricular preload. 3, renal sodium and water retention. 4, reduction in arterial vascular resistance to unload the failing ventricle. Or 5, myocyte expression of fetal isotypes of sarcomeric proteins? Which one does not happen as a result of systolic dysfunction?
Excellent. That is the way in which the cardiologist responds to systolic dysfunction, not the body.
A board-certified cardiologist.
Yes, board-certified cardiologist.
All right, a 44-year-old man with diabetes and arthritis presents with progressive dyspnea over the past 8 weeks. She has been treated with a brief course of antibiotics for bronchitis and albuterol for asthma, both without effect. Her other meds include azithromycin and albuterol. She doesn't smoke, drink, or use drugs. Her skin is tan. Her heart rate is 80. Her blood pressure is 122, and her JVP is 12. The lungs are clear. Heart is regular, low-pitched early diastolic sound. Abdomen is benign, no edema. ALT is elevated. Chest x-ray shows the heart is big. Sinus rhythm at 90 with no Q waves or SDT changes. The echo shows the EF is 25 with severe global hypokinesis. Which of the following is most likely to yield a diagnosis? Dobutamine echo, coronary angiography, liver biopsy, bone marrow biopsy, or thyroid function tests?
Good. So we're thinking bronze diabetes, right? She's tan. She's got the liver function element. So hemochromatosis is what we're going for here. And among these tests, liver biopsy was where you go.
And a 56-year-old man with diabetes, hypertension, microalbuminuria presents with weight gain and exertional dyspnea on metformin, glyburide, HCTZ, candesartan, and lovastatin. Heart rate's 80, blood pressure is 155, JVP is flat, the lungs are clear, there's an S4, there's 1+ edema, chest film shows cardiomegaly and pulmonary venous congestion. The labs are unremarkable except the creatinine is 1.2, HDL is 33, A1C is 8.6, mild LV enlargement with global hypokinesis and an EF of 30%. You advise which? Add carvedilol and aspirin, reassess in 6 months, refer for a defibrillator, intensify the anti-diabetes therapy, reassess in 6 months, refer for angiography, or refer for a Holter monitor.
Excellent. Lots of coronary risk factors, reversible causes, go for it.
All right, a 55-year-old man with grade 3 obesity is referred to you in the heart failure clinic. EF is 20%, class 2 to 3 symptoms, normal coronaries, no valve disease, normal iron, CBC, SPEP, and TSH. HIV is negative. He doesn't drink, smoke, or use drugs. He's been started on carvedilol, lisinopril, furosemide, DIG, and is feeling better. You recommend which? Bariatric surgery, sleep study, signal averaged ECG, biopsy, or a PET scan?
Excellente.
Each of these patients with heart failure and an EF of 25%, which is most likely to experience a significant improvement in LV function in the next 3 months? An 80-year-old woman with ischemic cardiomyopathy, 10% of LV viability on PET scan. 55-year-old man with Hodgkin's 33 years ago, treated with adriamycin and radiation. 3, a 72-year-old man with biopsy-proven senile amyloid. 4, a 67-year-old female with an ST elevation MI, peak troponin of 0.8, apical dyskinesis noted after learning that her husband had been in a motor vehicle accident. Or a 34-year-old woman with orthopnea and edema 2 weeks after delivery of her second child. Which is most likely to show improvement in the next 3 months?
Good. Excellent. And this would be number 2, the 34-year-old woman. So peripartum would be 50% at 6 months, but yeah, by far apical ballooning.
How long do you treat the apical ballooning?
I mean, I think 3 months is a good time to re-image. That should be plenty of time if it's going to get better.
All right, an aortic tracing is shown for a 43-year-old man undergoing cardiac cath as part of a workup for dyspnea and chest pain. Which of the following is the most likely finding on physical examination?
Okay, so here's the tracing.
There's the tracing, and so the question is he going to have increased JVD on inspiration, fixed splitting? Why don't you go ahead and...
Should I go back to the...
Go back so I can read the question.
Oh, right.
Fixed splitting of S2, a laterally displaced point of maximal impulse and an S3, a machinery-type murmur throughout the cardiac cycle, or an inspiratory drop in systolic blood pressure of 18 millimeters of mercury. Which physical examination finding is most likely?
No, I don't think so. Okay, so what are we looking at here on the aortic tracing?
Squiggly yellow lines.
Fluid-filled catheter, because there's all this artifact and stuff, but still, every other beat, the systolic pressure is down, up, down, up. That's not respiration. That is every other heartbeat. That's a problem with calcium handling in the myocytes. This is pulsus alternans. It's not pulsus paradoxus. So that's the trick here. So pulsus paradoxus is number 5. You'd see somebody with pericardial disease, tamponade, maybe constriction, something like that. So you would not expect that. So this is somebody with advanced systolic heart failure because they have very low cardiac output and very poor ventricular function, and that's why they have pulsus alternans. So we're thinking about what else would they have, what would travel with somebody who has really advanced HFrEF and low and poor myocardial function. And the most likely thing that we would expect to see is a dilated heart, laterally displaced apical impulse, and a third sound because they're probably going to be congested too. Now, for those of you, the 20% that said 1, that's true. That's a Kussmaul sign. An increase in venous pressure with inspiration should normally go down, so failure to drop or increase is a Kussmaul sign. We often think about that with constriction and restriction. We do see that in HFrEF, for sure, but not nearly as commonly as we would see a laterally displaced PMI and a third sound.